This is the Physical Activity Researcher Podcast, a podcast for researchers of sedentary behavior, physical activity, and sports. Join for a relaxed dialogue about research design, practicalities, and, well, anything related to research. Learn from your fellow researchers useful and relevant information that does not fit into formal content and limited space of scientific publications. And here is your host, researcher and entrepreneur, Olli Tikkanen.
Welcome, everyone. I'm very excited about the guest of today's episode and our forthcoming discussions about the role of exercise and nutrition in people with cancer. Our guest is working as a Post-Doctoral Research Fellow at the Exercise Medicine Research Institute at Edith Cowan University in Perth, Australia. He is the founder and CEO at REACH, a company designed to provide evidence-based guidelines of physical activity for people with cancer. Related to REACH, our guest is hosting a popular podcast. Ladies and gentlemen, I'm honored to introduce our guest, Dr. Ciaran Fariman. Welcome, Ciaran.
Appreciate it, mate. That made me sound a lot more important than I actually am.
All right, that's good if you feel like that. So, could you tell about your background and how did you ended up to Perth, which is probably the most isolated city in the world, I have heard?
You heard right. It definitely is the most isolated city in the world. Perth is unbelievable if you like beaches, which I don't mind beaches, but once you get sick of beaches, there is nothing else to do here. It's a really isolated spot, but great place to be and really learn a lot throughout my fellowship. And how I got here, I was born and raised in Dublin, Ireland, till I was about 18, and then went over to the States on a soccer scholarship because I was convinced I was going to turn professional, and quickly realised that I was useless and that wasn't going to work out. So during my college degree, I studied and got a degree in health science, and started to kind of pick up an interest in sports science and strength and conditioning. And I moved into a master's program down in Georgia in the United States, where I did a master's in kinesiology with an emphasis on body composition and human performance. So I worked in a body composition lab. We did a bunch of different studies on body comp, and did some sports nutrition studies, and did a bunch of kind of training studies on human performance. And it was a really cool insight into kind of the elite level of human performance and the most extreme level in terms of that direction. And it was just such a good experience, and it was such a fun. I couldn't believe it was a career where you just got to go hang out every day and test athletes and work with athletes. It was phenomenal, and at the time, I was kind of concurrently starting to get an interest in the area of cancer. And my own ma got diagnosed with breast cancer, and so while I was in that lab during my master's program, I did my master's thesis in individuals with breast cancer, where I was looking at the use of an anti-gravity treadmill in individuals with breast cancer. So all those experiences led to me getting a PhD or getting the opportunity to pursue a PhD at the Ohio State University up in Columbus, Ohio, which again was just a phenomenal experience. I had a lot of really cool experiences that I feel lucky to have had. So my first year there, I was actually allowed to go and intern as a strength and conditioning coach with a professional soccer team in the MLS with the Columbus Crew, which kind of gave me more of an insight again into that elite side of performance. And the reason I'm saying all this is because I took a lot of these principles into the exercise and oncology field. So kind of throughout that time, finished up with a year strength and conditioning experience. Did a couple of really cool studies, like we're about to publish a study where we worked with the world's strongest men and just tested their physiological profiles and just their freaks in nature. And I got to see the most extreme ends of elite human performance and capabilities at one end. And then throughout my time at OSU in particular, really dove into individuals with cancer and research in that space. So we worked with men with prostate cancer receiving androgen deprivation therapy, worked in endometrial cancer, worked a bit in breast cancer and head and neck. So started to get a really good understanding and appreciation for the reasons why we need to investigate exercise in individuals with cancer, and also how we can manipulate or look to target our exercise interventions based on what side effects they're experiencing with treatment, based on what we know that they're going to take a hit from their cancer or the treatment, and how we can combine exercise and nutrition to target those. So a lot of my research so far has focused on individuals with cancer, but I think what served me so well has been looking at those the elite side of performance and taking principles of training into the exercise oncology field, and taking my background in sports nutrition and using that to apply this to a clinical population, because human performance to me is all encompassing. If you talk about human performance at the elite level of pro athletes, I think human performance is just as, if not more important, in the clinical realm, and working with people at kind of the end of life and showing them or working with them to help them perform better in their daily life. And so all of that ended up in me getting the opportunity to come to ECU to pursue a postdoc. So I've been here for the last 2 years, where I've just been able to kind of really dive even further into that field of exercise oncology and look to see how we can use exercise nutrition in the management of treatment-related side effects for individuals with cancer.
Yeah, that's a really interesting background, that you have really worked with the world's most strongest men in the other spectrum, and then with the people with cancer. How do you see this as a continuum, and how do you see it different? Of course, it's different, but where are the similarities and where are the differences between athletic training and the training for cancer patients?
The easiest comparison, or kind of give you that continuum. So the continuum is elite levels or elite athletes working at the highest level of performance need to be so strategic in the management of their training stress, in the management of their recovery, in tailoring their nutrition to optimize whatever they're doing, optimize training and recovery, to manage their sleep and energy, and manage all these different things, that it's like a jigsaw puzzle. And at the elite level, you will do anything you can to gain an extra few seconds, an extra few kg, whatever your performance outcome is. If you go to general population like you or I, or the 40-year-old accountant who's just hanging out on a desk and has not trained before, most things are going to work for that person. If he or she gets off their backside and goes out and starts running and doing a bit of fitness, they're going to see some general improvements in health. They can take care of the nutrition and start eating better and start eating smarter, and they're going to see some general improvements in health. It's only then when they go that one extra step further that they start to need to think more carefully about their training and nutrition as they combine. So in the continuum, you've got the elite level, need really specified training and nutrition recovery. General population, most things work for most people. You do need to start to manipulate stuff, but these crazy training plans don't need to be as important. But then you go to the other opposite side of that spectrum, and you're dealing with clinical populations. You're dealing with an 87-year-old metastatic prostate cancer patient with extensive bone metastases. You have to be so careful of the training stress that you're giving that person. You have to be so careful in how you're managing day-to-day energy levels. You have to be so careful about how you're managing rest and recovery, how you complement the training with nutrition, and how all those pieces come together, just like they do at the elite end. They're even more important at the end of that clinical spectrum. And so even things like chemotherapy, we have a lot of people who train with us going through chemotherapy, and by nature of the cyclical or the cycles of chemotherapy, you have dramatic fluctuations in energy, fatigue, nausea, sleep, the works. And all of those changes cause changes in your readiness to train, or your motivation and physical preparedness to receive a training stimulus. So to my mind, it's identical to what I was doing in elite sport, because you were literally day by day managing rest and recovery, having an overarching goal of training and a vague guideline, but then you day to day had to make adjustments on the fly and had to really figure out how that person is doing on any given day to tailor their training.
Yeah, very, very interesting insights. And like you said, that you need to take into account daily energy levels and all pieces together. Would you say that holistic training prescription is even difficult for clinical populations than for top athletes? So how do you see it in terms of difficulty or challenges?
Oh, it's so challenging, so challenging. And I go back and forth in my own kind of personal perspective on this. I should pause here because I do, when we're talking about individuals with cancer, a lot of the time we can automatically start to think about the oldest, most sick, most frail person with cancer. And those people exist. And more often than not, they're the majority of people we work with. But at the same time, elite athletes get cancer, general population gets cancer, 30-year-olds, who are triathletes can get a diagnosis of early stage breast cancer. And so I'm purposely pausing myself because those people are understudied in our field because you automatically go towards kind of that more sick, frail condition. And so those people need a lot of care and attention as well, because the identity of an athlete can actually be removed as you're so it's analogous to getting an injury. If you're someone who's super fit, you trust your body, and you've been training fine, and all of a sudden you get a diagnosis and you can't do what you used to be able to do, especially something like type A endurance runners or endurance athletes who are so meticulous in their training, their body starts to not respond to training the way it used to. That is a really big hit psychologically, and there's got to be a lot of management there in the care and well-being of that athlete and how they're moving through treatment. So that's one area that I think is really important. But as you said, the idea of getting someone who is previously untrained, doesn't exercise, doesn't identify as an exerciser, for us then to say, okay, Samantha, now we're going to get you to train 3 or 4 days a week, and we're going to target your nutrition, and you're going to take supplementation, and we got to worry about your sleep. On top of, you now have got to deal with the emotional burden of a diagnosis, the financial strain of that diagnosis, the tangible shifts to your schedule as you're going through different treatments, as you're trying to manage the balance between if you're working and how you're managing the kids and the home life and all that type of stuff. And then the physiological and psychosocial hit of all the treatments. So you get surgery and you've got to recover from some surgery. Maybe you get chemotherapy and you've got to go back to the hospital once every few weeks, and this infusion can knock you out for a few days. And then you get radiation as well on top of it. So all of these things come together to make it infinitely more challenging to try and do this. But to my mind, it also highlights how important it is just to do anything. And that kind of highlights the role of exercise oncology. So if you look at the continuum of someone who's been diagnosed with cancer, so not talking about prevention, day one, you've been diagnosed with cancer. We've really started to define this into 3 separate phases. You can kind of get into the nitty-gritty, but ultimately the first phase is this pre-habilitation phase. Not unlike, again, what you would have for, say, an ACL surgery, where we know that the stronger the structure and function of that knee is and the tissues around it going into ACL surgery, the better your recovery is going to be. Exact same thing happens in cancer. We know that you're going to take a huge hit to the body. There's going to be a distress and insult of surgery combined with a lot of the physiological impact of chemotherapy or radiation. That's a stressful hit to the body. And so what we try to do in that prehab space is prehabilitate, get you as fit as possible so we can buffer as many of those side effects as we can. A lot of challenges to that area. It's really difficult to recruit to try and find out trials for that space. But then you move into the treatment space. And really the goal during treatment is just to hang out where you're at. If you train for 6 months during chemotherapy and you don't improve your fitness, that's a win for me. That's a win for me, because if you don't train, the risk of you having, pretty severe physiological side effects, body composition goes out the window. The risk of osteoporosis goes up. You lose bone mineral density, particularly if there's hormonal therapy or corticosteroids involved. Body fat goes up, lean mass drops, physical function drops. Depending on the type of chemotherapy, there's a risk of cardiotoxicity and reduced left ventricular ejection fraction and stroke volume. You've also got the risk of peripheral neuropathy, again, based on the type of chemotherapy. So all these side effects really need to be managed such that if you come out of this 6-month period, on average, and you're in the same physical condition as you were that you went in, that's okay with me, because then that leads you into that next phase where we've buffered the side effects of treatment. Now, once you're finished, can we get you back to living full of a life as possible? Can we now start to improve your fitness, improve your health and well-being, and all those things? And so really those three elements of that cancer continuum are what's important to us. Because you can also, in the survivorship phase, is that third phase, we can also get into palliation, where you've got a terminal diagnosis, and unfortunately, there might be months or so to live. And so really what we're trying to do in that space is just maintain physical function enough to try and maintain quality of life enough to give you a more wholesome, end to life, essentially. And so that, to me, is what is most fascinating about this, because if people aren't in this space, it sounds like such a niche area. It's exercise and cancer, man. That sounds so minute. It's a rabbit hole. And when you go behind the door of exercise oncology, it's this huge umbrella term that refers to different types of treatments, different types of cancer. You've got early stage breast cancer, again, compared to metastatic prostate cancer, compared to brain cancer, all these different types of cancer that bring about different physiological, psychosocial profiles. It's just such a fascinating area to be in, because there are so many challenges and so many unanswered questions. And really the value of exercise in these different spaces, ultimately the goals of it will change and the value will change as well.
This podcast is sponsored by Fibion, a research device that has been shown to be valid in tracking sitting, standing, physical activity and energy expenditure. Furthermore, Fibion has been shown to be valid categorizing physical activity into light, moderate, and vigorous intensity. In addition to scientific accuracy, Fibion provides automatically produced and easy-to-understand reports for research participants. Get scientific validation and learn more about Fibion at fibion.com/research.
And you said about the treatment phase that if after the 6 months there's no change, it's a big win. How is the situation if you don't do any kind of training? How much do you lose your muscle? How much do you lose your fitness? And how difficult it is to get back if you don't do during the treatment phase the training?
It's definitely pretty difficult. There's no kind of set rule of you will lose X amount of muscle. It is fairly variable, and ultimately the higher fitness you have at baseline is going to determine a lot of how much you can preserve, and it depends on the type of treatment you receive. So, for example, hormone therapy for prostate cancer is androgen deprivation therapy, which essentially takes away testosterone completely, and so you result in this castrate condition, and with that, immediately you start to lose muscle mass. And so over the course of 6 months, you could see anywhere from 2 to 6-7 kilogram loss in muscle, which is pretty profound when you think about the profile. If you're a 67-year-old man, you don't necessarily have 6 to 7 kg of muscle mass to lose. And on top of that, with the hormone therapy, you'll also see a concurrent increase, or an increase at the same time, of fat mass. So you might see a 6 or 7 drop in lean mass. You might also see an accumulation of 10, 12 to 15 plus kg of fat mass. And so you just see the stark differences of body comp completely change over the course of treatment. And in hormone therapy for prostate cancer, that's dependent on how long you've received the treatment and if it's intermittent or not. And so generally the changes start to accumulate over time, and they get worse the longer you're on it. And so people could be on it for years. More now, we're starting to move towards shorter ADT cycles where you're on it for maybe 3 to 6 months. So you might not see the same magnitude of changes, but it's still pretty profound. And then, chemotherapy for breast cancer, for example, chemotherapy can result in loss of muscle mass again, maybe 2 to 5 kilograms over the course of 6 cycles. And then with corticosteroids in particular, again, you can see jumps in 10, 15, 20 kg of fat mass. And there's a huge variability within that. And I'm not trying to escape that. But then you go to something like head and neck cancer. And so head and neck cancer literally is cancers of the head and neck. And sometimes you might have surgery such that you have part of the jaw removed. or you can have radiation to the neck to where you lose all sensation, or swallowing becomes really difficult. And with that, you have a really, really difficult time actually getting nutrition into the body. And so, for example, it could take you 2.5 hours to drink a smoothie full of greens and veggies or whatever, or a bowl of oatmeal, something that would normally take us 5 minutes. And so with that comes a bunch of challenges where you're losing a lot more weight a lot more rapidly. And also you don't necessarily have the energy to do a lot of intense exercise. And so that's where it comes in, the huge variability based on the type of cancer, the type of treatment, what we can expect to lose. But that's kind of to your point as well. The best case scenario is we preserve as much as we can, even if we take a little hit, because the closer you are to where you're at going into treatment when you come out is going to be the best case scenario for us to try and springboard off of that.
And you said about the difficulty of eating, and probably the appetite is also lower. How big do you see the effect of nutrition versus training?
I don't think it should be an either or conversation, because that is how it has been in our field for a very long time. Nutrition have been working in their own space and doing a lot of great stuff. Exercise researchers have been working in their own space and doing a lot of great stuff. Unfortunately, there hasn't been much collaboration. There's been a good amount, but not enough as far as tailored nutrition. So a lot of the work is kind of towards a plant-based diet or towards kind of a weight management type of diet, but the guidelines are fairly broad, and so we haven't got to the point where we're actually seeing this tailored nutritional approach, because it's very difficult to do, especially when you look at trying to do it with the numbers required to have an impact or be powered to detect these changes. You're looking at a few hundred people. Doing a tailored nutrition intervention at that level is pretty tough. But I think there's certain things, again, coming kind of back to my background, that are overlooked. And I think the protein requirement or the protein intake is dramatically overlooked in these populations. I think the role of nutritional supplementation is overlooked as well. It's starting to become a lot more prominent now, which is what's most exciting about the next 5 to 10 years, is because all these things are starting to come together. And I think from a practical perspective, coming back to the first question, we do have to consider the challenge of trying to change everything at once. So there's a really nice study by Nicole Koulos-Reed up in Canada that was looking at exercise and nutrition in head and neck cancer. And Lauren Capozzi was the first author, where basically they profiled people going through and after exercise interventions. And the summary of their findings was that people are really amenable to an exercise nutritional intervention, but they may not have the headspace, they may not have the capacity or the energy to do it during treatment. And so what they proposed from that was that maybe during treatment, particularly for something as intense as head and neck cancer treatment, where the treatment's a little bit shorter, but it is very intense, maybe that point, instead of trying to get you to exercise and do all this stuff right now, maybe that's the behavior change element. Maybe we get buy-in. Maybe we kind of keep trying to send home that message to you of the importance of this in your recovery. So over the course of 6 to 8 weeks, we've got you sold. And then as you move outside of treatment, then we start to get more aggressive with the recovery protocol. And so there's a bunch of different ways you can do it. And that, again, I think that's what makes it so exciting of we don't really know much about this space. We're just kind of going off a lot of theory right now. And the next 5 to 10 years are really going to open this wide open in terms of what we can actually change and the magnitude of that change with exercise and nutrition combined.
And yeah, I think that was interesting you said about headspace and maybe buy-in during the intense treatment. How do you see the psychology in this? Do we know enough how we need to do the things, but is it just that how do we get people to do it in this very, very challenging situation?
Yeah, behavior change is I think it's probably going to be one of the most important areas moving forward in any population, really. And this is one of those areas where it's not that different in individuals with cancer. The difference in terms of strategies you would use, maybe it's focusing on outcome expectation or goal setting or relapse prevention and things like that. What is different about individuals with cancer is that their barriers are different. So on top of the traditional barriers, haven't got time, I haven't got access, haven't got the money, all that type of stuff. You've got on top of that, you've got fear of safety. So my Aunt Jen said, you need to bed rest when you've got cancer, so I'm not going to do any exercise. I've got peripheral neuropathy and my balance is off, so I shouldn't exercise because my balance is off. Or I hear the word cardiotoxicity, so I'm not going to train because that means that my heart's bad and I don't want to stress it. And so you've got all these additional barriers on top of it, in addition to those things I talked about, where you're looking at the schedule of treatment, which influence their time availability, the financial implications of treatment, which influences their ability to afford the appropriate training. So it's not necessarily that the behavior change is different. It's more the issues that arise are slightly different based on what they're going through.
This podcast is sponsored by Fibion. Fibion is an accurate sitting and physical activity tracking device and analysis platform. It is a great tool for projects that aim for behavior change in sedentary behavior and incidental physical activity. Fibion provides easy-to-understand PDF and web browser reports for participants. Other features include comparisons to recommendations, linking results to health risks, achievement cards, and interactive goal-setting tool. In addition, Fibion provides an API that allows for easy integration to other systems and applications. Learn more about Fibion at fibion.com/research. Fibion, from researchers to researchers.
And how is usually the practicalities of the training? So is it home-based or hospital-based, and how does it change during the different phases?
It's pretty much a mixed bag of everything. There's some great researchers out there that are doing some really interesting work in home-based interventions. I'm not one of them. I'm not smart enough to do all that work, but they're looking to combine mobile apps and do home-based exercises. And then there's other people who are focusing on reducing sedentary behavior and just getting people active, which is an equally important area of research. And then you've got people who are also working in the hospital space. So us at ECU, we've got 5 different clinics throughout Perth. Some of them are gyms and some of them are directly in the hospital where we train people. And to my mind, a lot of the supervisors, the intervention is going to be targeted. So, for example, with prostate cancer and ADT and hormone therapy, inherently you're kind of leaning more towards resistance training to try and preserve lean mass and improve physical function and strength. I would offer that with the caveat of potentially using a resistance training primary approach with the combination of kind of a weight management approach from a nutritional perspective, where we're trying to maintain lean mass, drop fat mass, maintain or increase physical function and strength. And to me, that's the best outcome. Then you look at, say, anthracycline chemotherapy for breast cancer. Again, as I mentioned, there's a big risk of cardiotoxicity and reductions in left ventricular ejection fraction, stroke volume, mitochondrial function can also be damaged. And so there's a lot of impact there in terms of the cardiovascular system. So there's some phenomenal researchers. Lee Jones is one of them at Memorial Sloan Kettering, who do specifically supervise clinical work where they operate almost as a cardiac rehab clinic for individuals with cancer. And that has a huge role in getting buy-in and value to what we do. I think we do need to start to look at, not everyone can afford to go to somewhere like Memorial Sloan Kettering in New York or have access to an ECG and a GXT and all that type of stuff. We need to start to find viable alternatives for someone living in, I don't know, rural Switzerland with access to information and resources to be able to get them active. So I think the role it plays and what type of exercise we do differs so much based on all those things we talked about,
And you mentioned about sedentary behavior and home-based training. How do you see the importance of the continuum of physical activity, that on the other end you have sedentary behavior, then you have light intensity, daily activities, moderate intensity, vigorous, and then you have strength training and maybe kind of a daily resistance training, maybe climbing the stairs. How do you see the whole continuum and its importance?
I think the role and importance is massive, no matter what the element you're speaking about. The role and importance will differ based on the person. So someone like my mom, who is 62, has osteoporosis, is obese, inactive, and is a smoker, she's going to get a tremendous amount of benefit from getting up, walking around the block once a day. Anything that's going to get her in the right direction of habit forming in terms of physical activity. She could get a lot out of resistance training. We could try and preserve lean body mass, or even strengthen some of her musculature to absorb the load of carrying, I don't know, 110 kg of body weight around, which will definitely preserve physical function. But the how you do it and when you do it is so complex in someone like that, where there is going to be a lot of psychological barriers. You know, if you got knee OA, there's a bunch of pain, and I don't want to exercise because there's pain in my knees because I got knee OA, and I think pain or the exercise will exacerbate it. So that's the first target in terms of removing a barrier. Whereas someone like me, if I were to get prostate cancer in a few years, I've lived my life as an exerciser. I'm a former athlete, and I kind of am fairly in tune with my body. I would want to be on the highest end of that spectrum. I would want to compete. I'd want to do everything I could to maintain the highest level of fitness. And so I see the value in everything based on what's going on with the person's life. And it's less because there is this weird dichotomy, I think, between kind of the people who are on the exercise physiology perspective of like, you need to resistance train, you need to do this at X intensity. And there are substantial benefits to that. What I don't like is that some of us can get into this really arrogant mindset of physical activity is almost irrelevant. And the folks who are working so hard to find ways to reduce sedentary behavior, they almost get looked down on at times. And I think that is one of the most important areas. And then you take it out on even like the macro scale of your strategies to increase physical activity are almost irrelevant if the person isn't living in an environment that's conducive to that. So if you live up in rural West Virginia, up in the mountains, and it takes you 2.5 miles to walk to the local shops up and down the mountain, no amount of physical activity promotion, messaging, or behavior change techniques are going to work, because you're living up in a mountain and it's minus 20 for 6 months out of the year. And so I think we need to have this broader perspective of the individual level, the environment they're in, the supportive network they have around, to take all those into effect when we're talking about this at the individual level, you know?
Yeah, I see. So could you give an idea, how is the exercise, physical activity prescription, the realities? I mainly know about athletic training and then recreational training, but I don't know anything about training of cancer patients. So could you give an idea, pick up one example and walk us through how would it go?
Okay, so let's take someone on prostate cancer, or someone with prostate cancer who is receiving ADT. Let's put in chemotherapy there as well. So from that, I will say that we're going to have this combined program of resistance and aerobic exercise, and we're going to plan out this progressive training where we're paying attention to principles of progressive overload. And so to start with that, let's say they're completely untrained, I've moved away from body exercises targeting specific body areas, like, so this is your chest exercise, and moving more towards movements. And so I kind of break it down into, we want someone to hinge well so they can bend down and pick stuff up off the ground. We want someone to squat well so they can get in and out of the car. We want someone to be able to reach overhead. We want someone to be able to pull so they can pull stuff open or use those functions in daily life. So if we've got squat, hinge, horizontal push, horizontal pull, vertical push, vertical pull, and then break that down that way. So that's 6 movements. And then based on who you are, where you're at, for me, a squat and a hinge may be squatting with a barbell and maybe a barbell deadlift. But for our gentleman with the prostate cancer, who's 56 or whatever, his squat and hinge could be stand down, sitting up out of a chair, and his hinge could be focusing on hinge mechanics. So we have him in this kind of hinging position where all he's doing is working on his proprioception and his ability to hinge at the hips to prepare him for that future movement. So untrained person with prostate cancer, let's give him sit to stand, hinge. Let's give him, I don't know, let's say instead of, we want him to move his body rather than weight. So let's give him an incline push-up, seated row, probably working his mobility. So we'll do some wall slides, and then what else we got? Shoulder press. So that's pretty much the core of those movements. And then we'll repeat that 2 or 3 times a day. And then the order of those exercises will change. So maybe we'll start with lower body exercise on day 1, upper body exercise on day 2, start with lower body exercise day 3, and cycle that approach. So we're doing 3 days a week, starting at about 12 repetitions at a weight. He could probably do 14 to 15 repetitions just to get him used to it. Then drop down to 12 repetitions per each exercise. Start with 1 set of 12 week 1, maybe go for 2 sets of 12 week 2, then 3 sets of 12, and then continue on for that for 3 or 4 weeks. Start to gauge how he's doing, and then maybe you start to drop that more towards the strength continuum, where you look at more like, say, after 3 or 4 weeks we go 3 sets of 12, then we go 3 sets of 10, then maybe you go towards 3 sets of 5 or 3 sets of 3 to work on that kind of higher end of strength. And then you can sprinkle in some cardio. The reason I focus predominantly on resistance training, because the people we work with are predominantly not familiar with it. It's fairly intuitive to tell someone how to walk. And I haven't been a trainer for a long time. I kind of move away from, I don't need to be standing beside you on a treadmill watching you walk for 30 minutes. If you're at a super high risk, if there's a risk of cardiac event, or God forbid if we're doing a great exercise test, of course you need to stand beside the treadmill. But I'm not convinced that I need to do that for your regular training. So let's come into my clinic for 2 or 3 days a week. And then if you want to go for a walk with your wife or your partner, whoever, go do that. If you want to get a bit of extra training in the gym, maybe we'll do some interval training where that might require me to work more closely with you. And so that's a fairly kind of common example in the prostate cancer world. But you can get into specific nuances, say for bone metastases. So to keep this really short, the type of bone metastases will differ based on what type of cancer you have. So breast cancer, for example, the metastases typically foster or accelerate osteoclast activity. So what we have is cleaving of the bone. So the rate at which bone is being broken down is really accelerated. So if you have a metastases for breast cancer on a specific part, say the middle of your humerus, that specific point of metastases is going to get super weak and really intolerant to load, such that even if you move wrong, just using your body weight, you could have a fracture at that specific point. So we've got to be super careful about how we deliver exercise in that sense. Bone metastases for prostate cancer, the metastases actually facilitates osteoblast activity. So you have this hardening of the bone at a really specific site. And so the risk of fracture isn't necessarily as great as it would be for breast, but it causes a lot of pain with movement. And so we have to modify exercise in our own way that way. The research in this space is rapidly evolving, but our kind of best approach right now is basically avoiding exercise at a site of metastases. So if you have metastases in your right wrist, for example, we're going to take away almost every exercise that incorporates 2 arms. So you wouldn't do bench press, push-ups, seated row, stuff like that. That's going to cause some movement in the wrist, just out of precaution. And then the challenge then comes in if you've got extensive metastases all throughout the body. Then it's a conversation of really talking about the risks with the client or the person, letting them understand those risks and what's going on, and really letting them identify or kind of make that decision for themselves. Because There are some people that can have extensive metastases and have a great deal of physical function and really good mobility, and they're okay to move about. So this is, again, it's like the common theme for this is it's such an individual area, and those conversations happen at an individual rate as well, you know.
Very, very important points that you brought up. I like the idea, this movement-based training. Quite simple idea, but that you can hinge well, you can squat well. Do you see this should be important and the kind of basic principle for many other groups also, that you start from the kind of daily life perspective, what kind of movements you need, and do you know, is this used widely in other areas also?
No, it's actually it's kind of been a little mini area of focus for me, because I came from that area. So we're at a really unique point in the field of exercise oncology. A lot of the earlier work was done by nurses and physical therapists and some kind of clinical exercise physiologists who would have been trained extensively in aerobic training, which resulted in some absolutely fantastic studies in our understanding of the safety and feasibility of exercise, which was great in its own right. Now we're at the point where we have this platform of safety and efficacy. Now we're looking to do safety and feasibility. Now we're looking to do efficacy. And to do that, we do need to get more strategic in our exercise planning. And so because this is done a lot of times in hospital clinics, people are working with minimal amounts of equipment. So you might only have a leg press machine or a chest press machine. So that's all you do. For my best case scenario, everyone should be on that movement scale. Where I'm at right now, my philosophy anyway, that might change. But I think we do need to have a strong emphasis on, these people aren't trying to be bodybuilders. They don't need to do lat raises. They don't need to do calf raises. We need to figure out the exercise that are going to give them their biggest bang for their buck to result in the best amount of benefits, and these exercises that stimulate whole body musculature. And then that's going to result in improvements in their activities they live in. So that can be, to my mind, something like a deadlift. People are often kind of not necessarily afraid of it, but hesitant when I say, yeah, we have people with prostate cancer deadlift, and they could be 76 years old. They're not deadlifting with 150 kilograms. They've gone through all the movement patterns. We've gotten them to be able to hinge well at the hips, so they've worked on their mechanics for weeks. Then we've gradually progressed them towards, say, a kettlebell hinge. So they have a kettlebell between their legs and they're still just reinforcing that mechanics just with load. Then we progress to kettlebell RDL, a Romania deadlift, where they're working more on greater range of motion with that hinge. Then we progress to maybe a trap bar or a hex bar deadlift, where it's a little bit easier to kind of intuitively pick up that movement. That to me is a huge benefit. If you can get to a point that we've got people in our clinic now who are deadlifting 80, 100 plus kilo, that to me, it's one of the best exercises you can do for a whole body. So even if you were to wipe out everything as a 70-year-old man, you were to master the deadlift and you could get that down 3 days a week, that's going to result in some pretty big benefits to your ADLs, you know?
Yeah, I fully agree. And I like I said, I really like this idea, and I think you should work on it to get it more widely used. I think it's really, really important, and I fully agree that the deadlift is underappreciated with normal population. When you do it right, it's a really good movement and relates nicely to the daily life.
I should fight with myself there. I also want to highlight the role of physical therapy. So we're talking about from the perspective of exercise physiology and whole body fitness. There are times where all of that is inappropriate, and immediately post a mastectomy surgery, for example, or again that head and neck cancer, we might need intensive physical therapy during that space. And it's important for us as EPs to not step on their toes and realize the importance of physical therapy. So I wanted to throw that caveat in there because I oftentimes can get so passionate about the exercise physiology that people think that I'm saying that physical therapy doesn't have a critical role, because it does.
Yeah, that's a good point. And And like you described this training progression and so on, so it seems quite classic in a way from the training science.
This podcast is sponsored by Fibion.
My name is Terje Gjøvåg. I'm associate professor at Oslo Metropolitan University. Currently, I'm using Fibion in a project where we investigate activities of daily life in people with lower limb amputation. My impression is that Fibion is easy to implement in this project. It's easy to use, and it's also simple to upload and analyze the data.
How do you see, for example, in the pre-habilitation phase that maybe people are not perfectly motivated, maybe they don't have time to or motivation to do it like this? How do you see kind of the minimum dose approach? And if they don't have gym, they don't have facilities, how do you get them to do at least something?
Oh, that's a $1 million question, man. I think the difficulty is that it's so much more than motivation. Some of it, the time to surgery can be rapid. So you get a diagnosis on a Thursday and you've got surgery 2 weeks from now. What are you going to be able to do from a fitness perspective in 2 weeks? And if you can't really do much, is there a point on doing it? And so the time that you have in that prehab space can be a couple of weeks, it can be months. And so the time we have to actually do something is going to be different as well. And again, because what we try to do in a lot of our studies is recruit people at diagnosis. But if you've just heard that you've got cancer for the first time in your life, you're not thinking about exercise. You're thinking about, how do I tell my partner? How do I tell my kids? Can I still work, or do I have to quit my job? How am I going to pay for this? The last thing you're thinking about is, where can I find a squat rack? And so really I think for us, it's trying to demonstrate the value that we think it might play. But there's a difference between being an advocate for it and an evangelist of it. So I love exercise. I love what it does for me. I love what it's done throughout my whole life. And I feel like it plays a big role in my life and my quality of life, my physical fitness. I think it can play an important role in buffering some of the side effects of treatment. But at the same time, I'm not so kind of sold on it that I'm going to try and convince you that you have to do this no matter what. It's the single most important thing in your life right now, because it's not. It again, come back to the elite level. It's the role that strength and conditioning professionals play in pro sports. We have an important role, but at times it's not the focus. You know, we have an important role as EPs to try and sell this, or to try and demonstrate the role of exercise. But there's times where it's just like, let life take over. And so I don't have any specific strategies for it, because again, it's like, is this something that's worth your time? Is it something that you can just get out of the house and walk around? Maybe it is a home-based approach that's most appropriate for you right now because you don't have gym equipment. Or maybe you do have the headspace and you do have the ability to get to a clinic, so we'll do some gym-based stuff and we'll try and improve your fitness that way. Because on the other end of the spectrum, talking about evangelists, we espouse the role of exercise in people's lives. But if you've got terminal cancer and you've got 3 months to live and you come and tell me that you want to go live by the lake and eat some pizza, who am I to turn around and go, actually, you should be squatting? You know what I mean? Like, I really enjoy exercise and I think it's important, but I'm not so sold that I'm willing to ask you to forgo your last months at the lake because you need to come to the clinic and do a few squats. It's about seeing what the magnitude of change is, and is that magnitude of change important to that person? Because what's important to me is largely irrelevant. I might think your bone mineral density is important. You might not give a toss about that, and all you care about is being around your family, and you're willing, or you're recognized that your quality of life might drop off quicker without exercise, and you're cool with it. And so I'm cool with it. You know what I mean? It's not me. It's not my job to demand you to do anything or tell you what to do. It's just showing you what we know and showing you what we think. And if you want to try it out, I'll give you strategies to do so. But I'll never be so sold on it that I'll try to coerce or force someone to exercise when they don't want to, you know?
Yeah. So probably quite a lot of consideration that how difficult situation people actually really are and what they are capable of doing. Yesterday I had a podcast recording with the medical doctor from Switzerland, and he was telling about his use of activity tracker to motivate normal unfit people and some patients. Have you looked to activity trackers at all?
I haven't specifically. There are a lot of people in this field that are doing a great amount of work in the space of activity trackers, and I know it on a peripheral level to know that it has some value. But I don't do it myself, no.
Yeah. And now we have talked about general things related to exercise oncology. What kind of specific projects do you have ongoing and forthcoming?
I've got a lot of really cool stuff, man. I have a dream job for what I do and what I'm interested in. I'm in a space in my career where I'm working with some really brilliant people on some cool projects. So a couple of key ones. I'm leading a project looking at the role of creatine supplementation and resistance training in prostate cancer, looking at its effects on lean mass and muscular strength. Again, creatine supplementation is one of the most widely studied, safest supplements, and has been demonstrated in a whole bunch of similar populations, older adults and clinical populations, to improve lean mass and strength. And so if there's anyone that I think could need it, or at least warrant us looking at it, I think it's prostate cancer and ADT. So that's the main project I'm leading right now. But we're also looking at if exercise can improve the tumor microenvironment during radiotherapy, and seeing ultimately if improving the oxygenation of a tumor can make it more sensitive to radiation therapy in individuals with prostate cancer, which is really cool. I'm also involved with a really brilliant group in Dublin, Ireland, looking at recovery from esophagogastric cancer. From their treatment. It's a really intense treatment, and the recovery is pretty rough as well. So the summary of what I do right now is I'm looking at it. If you've been diagnosed with early stage cancer, can we delay your time to treatment? Working on a bunch of projects right now during cancer treatment. Can we buffer some of the side effects? And then peripherally involved in some projects looking at if we could work on advanced cancers to see how they tolerate exercise as well. So we're about to publish a couple of projects in individuals with cancer with spinal metastases, which is pretty challenging. Nick Hart is the lead on that, does some great work in that space, and we're just trying to see if it's safe for them to exercise and if we can actually load the spine. So some really cool projects, and I'm fortunate to be learning from a lot of great people in that space.
Yeah, really, really important and relevant projects. If you're looking for some parties to collaborate with, what kind of expertise you would be looking?
Anyone who's interested in this space. It's wide open. We need more people. I will say some of the more important areas, we're looking at basic scientists. So we have a pretty good understanding at the applied level of what happens. So we know what happens to strength. We have a decent idea of what happens to body comp. That's a bit of a messy area. But I would love to look even deeper at the cellular level and look at what's going on in the muscle itself and muscle morphology, because it's been way understudied in this space. And I think there's room for a lot of collaborations between basic and applied scientists, particularly when you start to branch into things like cancer-related cachexia, which I'm interested in. The basic scientists have done a ton of really good work, and some applied work has been out there, but no one's really talking to each other. So that's a huge area. Registered dietitians, or people with a sports nutrition background, are desperately needed to collaborate and to get in on trials that can deliver these targeted interventions, come up with unique ideas in terms of supplementation and integration there. Behavioral scientists are absolutely key. People from a technology perspective, again, even like you said, activity trackers, or any way we can use technology or even AI to try and enhance the effectiveness of our programs. And then a really big area is implementation science. So anyone with a background in the area of implementation science and how to design and evaluate projects to enhance their efficacy from an implementation perspective and their feasibility perspective is going to be huge. So all comers really.
Yeah. So if you're interested in collaboration, be in contact with Ciaran. I think it's really important work. And probably you following the general strength training scientific literature. So what do you see as the most interesting new things in the strength training science at the moment?
The strength training science, I think one of the most interesting conversations that's ongoing is this idea of if periodization exists. So there was a couple of really, really good papers from a guy called John Kiley, one in 2012, and I think the other one was 2016. John Kiley is a strength and conditioning coach who's worked in elite rugby for, God, the goods of 20 plus years. And he wrote these really cool papers that basically were asking us to think more critically about this idea of periodization and asking the question, is it periodization or is it just programming? So the theory of periodization is that there's kind of these natural sequence of development where you move from high volume, low intensity to low volume, high intensity, focus on specificity as you get right down to an event. And the natural sequence of progression is you move from hypertrophy to strength to power in terms of the sequence of training. And a lot of that theory from Matiev was kind of based on this Olympic training model where you have to peak for a single event. And John Kiley kind of had some great discussions in these couple of papers where he was just kind of saying that idea works well for certain sports, but it's not all encompassing. And at the level that he's working at and the amount of athletes he's working at, you don't have time to progress from hypertrophy, a specific hypertrophy phase to a specific strength phase to a specific power phase. You're kind of working on all these things together. And if you start to take apart the areas of periodization that aren't necessarily involved in the theory, he kind of goes back to, it's just kind of common sense. If you adhere to principles of progression, principles of overload, if you manage stress, manage rest and recovery, your training plan is going to lead to some substantial improvements. So to me, it was a really cool conversation that sparked a lot of further conversation from different experts in the area. And it's kind of an ongoing, I won't say debate, but it's an ongoing topic of discussion, which I think is really cool. And I think the second more important one that we're looking at is this idea of cluster sets. Cluster sets have been around for a long time. Again, coming from Olympic type work, Olympic lifts where you're looking at like snatch and clean and stuff. The idea between cluster sets was instead of doing, say, 6 repetitions in a row or 5 repetitions in a row, could you break those 5 repetitions up into sets of 1 or mini sets of 1 or mini sets of 2, separated by 15 to 30 seconds rest? And the goal is, if you're doing a snatch 5 times in a row and you're lifting this barbell all the way over your head, it's really exhausting and it's hard to maintain power to such that your power will decline across your repetitions, where your fifth repetition will be a lot weaker or slower than your first repetition. So if you have these little mini rests in between, the idea is that you maintain power, maintain quality of the work, and have a greater session and ultimately lead to greater adaptation. Really cool concept. We're starting to look at it in a clinical perspective. We've got a really brilliant collaborator, Carolyn McIntyre, who is doing some phenomenal work in advanced lung cancer. And we were talking, and she was explaining to me a lot with this idea of breathlessness and discomfort. She was saying that people with lung cancer, or the specific population she works with, mesothelioma, can have this breathlessness that actually limits their ability to do exercise. And so what happens if you're doing resistance exercise is that you automatically drop the load or drop the weight to match their breathlessness. What happens because of that is that you're actually not giving them a load that your muscles can handle. You're giving them a load that their breath can handle. So then we start to spin our wheels and go, oh, well, maybe if we include these additional rest periods, maybe that will allow for, again, the minimization of that breathlessness and reduce levels of fatigue, such that maybe they can perform a higher level or higher load of training that may improve them better than otherwise. So we're looking to see if cluster sets will actually ward off feelings of or symptoms of breathlessness and discomfort to potentially enhance their training. So again, that's another example of really specific strength and conditioning type training brought into the clinical population, where I think it can have tremendous value as well.
Yeah, I like the idea. I haven't read about the cluster sets. I have been thinking by myself when I'm doing training, and also that usually the training is taught with the athletes that you have, for example, 1 to 3 training sessions per day. But some of the things you could do throughout the day. For example, if you would be like a 400-meter runner and you would have all the time in the day to train, could you do it that you do one sprint at 9 a.m., second one at 10 a.m., 11 a.m.? Would it be more effective if you could make it practical? And same for this strength training, that of course you cannot have a too long break between the repetitions. You need warm up, you need to so on, but like how much you can have a break between. And then I think it also comes kind of to this daily activity, that if you can do, if weaker persons can do their strength training stimuli with the stair climbing, then they can have them like spread out throughout the day, which might not be the same effect as you do them consequently, because it gives different stimuli to the body. But I think it would be good that we think it more broadly and not always like as exercise sessions or that you do a set.
Yeah, I think with the 400-meter runner, I think it depends on the adaptation you're trying to do. Like if you're trying to work all out top speed, the more rest you have between those efforts is going to be really important. But if you're trying to improve buffering capacity, you need to have that interval type training. But then, as you said, the separating aerobic from resistance is probably going to be important in minimizing any competitive inhibition there in terms of adaptation. We know that if you're going at the extreme ends, if you're trying to build as much muscle as possible, aerobic exercise will interfere with it, and vice versa. If you're trying to build as much aerobic capacity as possible, resistance training will interfere with that. I can say that, again, it kind of comes back to how much of an impact that has. There's only been one trial right now that's demonstrated a degree of interference effect, and that was in prostate cancer, and it was aerobic and resistance training combined versus either together. And to my mind, the interference effect wasn't enough for me to go, we need to revolutionize the way we think about training. And I think, of course, the best case scenario is to separate all these things, but we have to be strategic in how we do it as well. It's got to be practical in paying attention to people's time. Our best laid out plan on paper, if someone's not going to do it, and again, if they're looking at 5 or 6 days a week of training because we've given them all this rest and recovery, versus 3 days a week where they have a few days off, we don't necessarily know how someone's going to look at that and go, I'll actually prefer the 3 days because I can just get it done. So all those individual factors come back into it again, you know?
Yeah.
I don't have a clue what I'm talking about, man. It seems like the answer keep coming back to is individualized factors.
No, it's good. And how do you see, you said this, does periodization exist? So basically you can periodize the training, or you can kind of undulate that you have everything kind of, not all the time, but most of the days. What's your take on it? Should you do it with athletes? Should you do it with cancer patients?
I think there's an overemphasis from a theoretical perspective in both. So what you have is a lot of people who are really familiar with periodization are often only one sport athletes. So bodybuilding, it's fairly prominent. Powerlifting is fairly prominent. Olympic weightlifting is fairly prominent. And those people will use that to project that onto team sports. And if you are a bodybuilder and you want to periodize your program where you focus, and periodization from a bodybuilding perspective is, I'm going through a mass phase, then maybe I'm going through a strength phase. I don't really worry as much about power, but then maybe I'll go through a mini cut phase. Powerlifting is very specific, where they try to target all those: hypertrophy, strength, and power. And you can do, from a linear perspective, linear periodization would be, say, 8 weeks is hypertrophy, take a deload week or whatever, 8 weeks of strength, and then 8 weeks of power. And how undulating periodization came to effect was that people were kind of going, well, if you train 8 weeks for hypertrophy or 12 weeks of hypertrophy, whatever your block is, are you at risk of losing a lot of those gains if you don't train from a hypertrophy perspective when you go into the strength or power space? So then they started to move into kind of undulating models where you would do 1 week hypertrophy, 1 week strength, 1 week power, or even one day within an individual week, you would do day 1 hypertrophy, day 2 strength, day 3 power. So there's a bunch of ways you can figure this periodization. At the elite level, at the elite powerlifting level, those changes in programming can make a big difference. Because if you run one program and you see an increase in 5 kilograms, and if you ran another program, you might not, or your program wasn't effective, that 5 kilogram could be the difference between you winning and losing a meet, winning and losing national competitions, all that type of stuff. So it's really important. From an exercise oncology perspective, it doesn't make sense, because what is periodization? You're trying to manage, from a theoretical perspective, you're trying to follow this natural sequence of training, focusing on hypertrophy, strength, and power. And if we're talking about the majority of the people who are untrained, older adults, if you put them through any program that has the underlying principles of progressive overload, they're gonna build strength for sure. Any type of training modality is going to improve strength in untrained people, most training modalities. Hypertrophy will lag based on the treatment complications that we're having. But more often than not, when you're untrained, you respond to pretty much any stimulus. I would say periodization, and whether you follow like a 3-1 loading block where you progress for 3 days or 3 weeks and you drop a deload in there 1 week, or a 4-1 block or a 5-1 block, those specific nuances of periodization are irrelevant as long as the program is rooted in principles of progressive overload, in that the overload means that your training is kind of more than what your body could normally handle, and it's progressive such that you're progressing that load over time. As long as those two principles are set, and you put on individualization on top of that, so you or I are receiving different training stimulus because we're different people and different psychological profiles and physiological profiles. And then you put rest and recovery on top of that. As long as you're hitting those 5 key principles, the specific loading paradigm, whether you do weekly undulating or a linear 3-1 block, is largely irrelevant, because the signal to noise ratio is so large. So if you're a powerlifter working at your max capacity and you've been powerlifting for 15 years, 5 kg of strength in, 6 to 8 weeks is huge. But if you're someone with cancer who hasn't trained before, and we take you through a training program, you might see a jump in 40 kilograms of strength in 6 weeks. And so that signal that we're getting from training is so big that the variation when you ran a 3-1 program versus a 4-1 program, if that results in 5 kg difference in strength, does it matter? Probably not. Especially when you talk about the only reason you're doing that is to improve ADLs. So you can't tell me that if this person improved their squat strength by 5 kilograms more than another program, is that 5 kilogram going to lead to any meaningful improvements in physical function or ADLs? Because if it doesn't, what's the argument about?
Yeah. It totally makes sense, and I can really see that it helps you to have the expertise and the knowledge from the athletic training, that you can bring that knowledge to the clinical side. So I really like your thinking, and I pretty much agree. I've been playing baseball for a semi-professional for 20 years, and then I started to martial arts, mainly kickboxing and Thai boxing, and I don't really see the classic periodization working there. You just try to kind of manage all aspects of your fitness or performance. Although I think like you need to have blocks that when you do kind of basic training, that you're actually doing strength training. You cannot really do many of the techniques. I cannot do a high kick without tearing my hamstrings when I've been doing doing the squats few days before. So I think you need to kind of have some kind of periods where you do something. But yeah, I think it is more complicated than the classic periodization. Yeah, I think it's been really interesting discussions about exercise oncology, and we should probably wrap it up. I think one important question I wanted to ask, that what have you learned about life working with people with cancer?
I think that is a great question. Wow, what have I learned about life? I think it's infinitely precious. What I've learned about life for me is that I hit the jackpot with my career. This is the most rewarding thing I've ever done. I've been in elite sports. I've worked with the most strongest people in the world, and that is cool in its own right. But it doesn't even come close to this for me. The reward of being a source of positivity in someone's life when they've got a lot of other stuff going on, working with people who are previously fearful of resistance exercise, who may not be, comfortable doing it, and getting them to a place where they're proficient to do it on their own. Honest to God, it's one of the most enjoyable and rewarding aspects of what I do, and I feel so fulfilled from it. And so what that has taught me is that when I've moved into a point in my life of just service and moving toward to serving others, it filled my cup up completely. And that has just made me double down on that. And really now my whole philosophy is to just, move through my life from a point of service and do whatever I can to help people and lift each other up, and just kind of be that source of positivity out there.
Yeah, it's really nice to hear how happy and how fulfilled you are of your work now. It's really, really inspiring to hear those words. And yeah, I think we should wrap up. What are your final remarks on the topic?
I would say to anyone listening who's not familiar with this, the biggest takeaway I'll give you is that training hard for us, training hard is relative. So when I talk about people training on the high intensity of 1RM or doing strength training, intensity is relative. And so a high intensity of 1RM for us could be a 100 kilogram squat or 120 kilogram squat. For someone with cancer, it could be a sit to stand and getting out of a chair. And so this is not me saying that people with cancer, and particularly people who are sick, frail, and weak, need special care and attention. What I'm saying, and I live this truth, is that we don't get to put that label on them. We don't get to tell them that they're too weak or too sick or too whatever to exercise. We let them decide, and our job is to empower these people, not to give them another barrier to exercise. So we have to remove our fear of the disease and the treatments, and train ourselves, obviously, in the background, the pathophysiology and the treatment side effects, that we can provide exercise prescription appropriately. But if you have those nailed, this can be a really safe and powerful tool for you to improve physical fitness and quality of life in these folks.
Yeah, really, really important points. And thank you, Ciaran, for taking the time for this podcast. It was really a pleasure talking with you.
Thanks so much for the opportunity, mate. I enjoyed it.
This podcast is sponsored by Fibion. Get scientific validation and learn more about Fibion at fibion.com/research. The Physical Activity Researcher podcast has created an activity tracker purchase guide for researchers. Get your free copy from the link in the podcast description.
Thank you for listening to the Physical Activity Researcher Podcast.